What's up, everybody? Cam Meekins here. This is the Cam Meekins Show. I'm honored to have a very important guest with us today, here to discuss the COVID-19 pandemic, Dean of the Brown University School of Public Health, Dr. Ashish Jha. Dr. Jha, first off, just thanks so much for coming on the show. Really, really appreciate it.
Hey, Cam, thanks so much for having me on. I'm excited to be on.
Yeah, no, me too. You know, I was telling you before we got on, you know, I've got younger listeners in their 20s, and I had this idea for a while to talk to you and just kind of, you know, get people in my generation a little bit more engaged with what's going on. And so I just, you know, I'm super excited. So I want to start by asking you about the new strain of the virus that's initially been identified in the United Kingdom. We're hearing that it's more infectious and, you know, potentially, more infectious, but not necessarily more deadly.
Yeah.
So I was just wondering, what can you tell us about that and the implications it might have on the rate of infection in the United States, or is that already happening? Do we know?
Yeah. No, it's a great question. Great place to begin. So let's take a step back and think about strains of viruses. You know, viruses, any virus has mistakes that it makes when it's replicating itself, when it's reproducing itself. And most of those mistakes don't mean anything, that they basically have no effect. But a few of them essentially become mutations that can become a strain. So what constitutes a strain? We say something is a strain if it acts differently, if it functions differently, because most of the mistakes that a virus will make in replication has no implications whatsoever, right? It's something minor.
Right.
But what happens with this is, so there have been talk of new strains of this virus throughout the whole pandemic. This is the first time we've actually seen real evidence that there's a new strain. And this strain, identified in the UK, and we can talk about why it was identified in the UK, really does look like it's more infectious. I don't know, 30, 50% more infectious. What does that mean, by the way? Just sort of on a practical level. It means if you were exposed to the virus, your likelihood of getting infected is higher. So it's not some magic virus that if you are not exposed, you'll get infected. You still have to get exposed, right? So you still have to spend time with somebody who's infected with this strain, but your chances of catching it have gone up about 50%. It was identified in the UK because they're actually doing a really good job of sequencing all the viruses, not all of them, but a large chunk of the ones that they're seeing. We're not. So we have no idea whether this strain is running wild in America or not. We just don't know because we're not sequencing. We're not looking for it. My best guess is that this strain probably is here in the United States. Everywhere people are looking, they're seeing it. And it does appear to be more infectious. Thank God it does not look to be any more deadly. So if you get infected, doesn't mean you're any more likely to die than from the previous strain. And I don't think that there's any reason right now to worry that the vaccines that we've been developing are not going to work against this strain. So far, that part also looks good. But, you know, if something is 50% more contagious, it means we're going to get a lot more people getting infected, a lot more people getting sick. And that, of course, unto itself is a bad thing.
Yeah, you know, I mean, I live in LA, and obviously the cases are going crazy. Even in just Los Angeles County, we had 30,000 cases today. I think 60,000 in the state. You know, shocking numbers. And the graph has just been looking just exponential.
Yeah.
And of course, you know, we've got this Thanksgiving surge now, surge on a surge with the Christmas, you know, thing, which I'm sure we'll talk about. But, you know, I'm wondering, you know, or I was wondering, and there's no way to know until they've done the tests, but is this already spreading in the United States? You know, I really was worried about that given how bad it's gotten recently in California. And I'm curious, when they say more infectious, you know, what kind of tests are they, or, you know, what kind of studies are they doing to determine that? It seems very complicated to me.
It is complicated. There's no simple way to do it. And there's a lot of easy mistakes to make to sort this out. So basically what you do and the way you figure this stuff out is you first look at all these kind of different strains and you say, do you see one kind of becoming dominant? So in any given country, you might say, okay, 10% have this mistake, this 10% have this other kind of error in there. And you can track virus, kind of different versions of the virus using those little markers. If one of them all of a sudden takes off, goes from being 10% of all the infections to 60 or 70% of all the infections, you go, whoa, there's something about that virus that's giving it an advantage, that it can spread more quickly. Now, even that is not enough information. You got to actually go look at the genetic stuff and you got to figure out what is it about the virus And is there something biological going on? What's happening with this virus is that it has a very specific change in its genome, in its genes, that allows it to actually attach to human cells a bit more effectively. So now, let's say you're hanging out with somebody, you're talking to them, they're infected, and a little bit of that virus gets inside of you. In the previous version, the normal version of this virus, there's a chance you'll get infected, but there's a chance you won't. This one, the chances that you'll get infected has gone up because, again, that virus's ability to bind to human cells is a bit better on this one. So that combination of looking at the data across the country in the UK and saying, wow, this strain really seems to be taking off, and the biology that says, oh yeah, here's something that's specific to this virus, that combination is what's giving people confidence that this strain really is different, that it really is more contagious.
So that's that spike protein difference. Is that essentially what it is? It connects to the ACE2 receptors more tightly. Is that an analogy?
Exactly. So you're 2 steps ahead of me. And so basically what, again, for people, I don't know how much people know about the virus, and the very basic thing about the virus, the reason it's called a coronavirus is from the I think Greek, maybe Latin, I actually don't know, the term for crown, right? And so you've got kind of a ball, and then you've got these little spikes that look like a crown. And those spikes are these spike proteins. And that's what the virus uses to attach to a receptor on human cells called the ACE2 receptor. And that's what it uses to basically infect the human cell. And the genetic mutation of this strain allows that binding to be a bit tighter, a bit better. And so it makes the virus just a bit more efficient at infecting human cells.
So I don't think I've heard about this recently a lot, but earlier on I heard a lot of talk about the viral load, and a higher exposure is more likely to lead to more serious illness or maybe quicker illness. Is that true, or is that a misconception? And does that are those factors changed at all with this new variant that we've identified? Because
sorry, go ahead.
Well, just because this one is more infectious, so is that out the window, or?
No, it's a very good question, Cam. And I'll tell you, this is where the science is not only not clear, you've got really good scientists debating this, and there are different camps. So let's walk through the science of what we do know and then where there is disagreement. What we do know is that viral load matters. So what does that mean? It means if you get a tiny bit of the virus, you may actually not get infected because you need a certain threshold, a certain amount of virus before you can get infected. Okay. One of the ways that masks are so good because they decrease the amount of virus that you put out. So even if a little bit of virus gets out, it's much less likely to infect somebody. Now, one of the questions that has been out there is if you get a lot of virus, is that worse than if you get a moderate amount, as long as both of them are above that threshold for infection? And for other respiratory viruses, there is evidence that the more virus you breathe in, that initial load, the inoculum, the sicker you're likely to get. There are really serious scientists on both sides of this debate. One group says, yes, that's true. Another group says, we don't know that is true. So we don't know. And my general take is, when you don't know, better to presume that the answer is yes, and you should try to avoid how much virus you breathe in. But viral load that is a really important issue. And then the other part we think is, if you have a high viral load yourself, you probably are more likely to be infectious to others, which of course then begs the question, well, how do I know if I have a high viral load? How do I know when I have a high viral load? And there is some data on that, which we can talk about. But there are windows of time where people are most infectious, where they're most likely to give it to somebody else.
Got it. So is there any reason that we've now seen these mutations happen? So I guess I'll step back for a second. When the original Wuhan variant was identified, then it was in Italy, and then it seemed to change in Italy. And then there may have been a time where both of the strains were predominant in the United States. And then did the Italy one take over? Is that correct?
Yeah. So, and again, whether it's a truly different strain or not is a bit of a semantic, but let's call it a strain for now. It's fine. So you have the strain that came through Europe and a strain that came directly from China. And what it looks like is the thing that really took off in Western Europe ended up really landing in New York and wreaking havoc in the early days of March, April, May, was the strain that came through Italy. And we don't actually think that it was any more contagious than the original Wuhan virus. We just think it's what people talk about as a founder's effect of like, look, New York has a ton of travel from Western Europe. So
Right.
You're not going to be surprised that the virus that lands in New York is coming from Western Europe, much more than the virus from China directly, right? And so that's what happened basically. And we don't think it's a separate, like, you don't want to think it's any more contagious, but it does look like that was the thing. The other thing to remember is that this virus is global. There are literally millions of people getting infected every day. So there are just tons and tons of mutations happening all the time with the virus. And you can track those mutations to see where the virus is spreading and who's spreading it to whom. But most of those mutations, as I said, don't have a functional meaning, one mutation versus another, they don't actually mean anything from an infection or deadliness point of view. This is one of the few times where it looks like it really is different.
Yeah, I got you. And so, presumably the more community spread that's happening, the more infections that are happening, the more, variations are going to occur, right? So obviously the United States being pretty much the hub of the virus for the last, 6 months or whatever chunk of time, like you would imagine that there's these variations taking place right now. Are we just not tracking it as good as Europe? Because now we've seen, 2 identified variations of the virus coming out of Europe, but we haven't done that work on our end.
2 really important points there that I think are worth emphasizing. Number one is if you don't want a whole lot of different variations and mutations, you got to stop the spread. Every time the virus spreads, you're giving the virus more chances to mutate. It's just simple math. And so, there's a crowd of people out there who are like, let the virus spread. And I'm like, don't tempt fate. Don't do that.
Right.
So the best way to avoid lots of mutations is to avoid lots of spread, because every spread creates more opportunities. Yeah, now the question is, so if America is the really kind of hotspot of spread across the world, why are these mutations coming from the UK or South Africa? It's because those guys are actually sequencing the genome of the virus much more than we are, probably 10 or 20 fold as often as we do. So if we're not looking for these variants, we're not finding them. But that's why I feel pretty confident that that variant from the UK probably is here in the United States.
And we don't know that it necessarily started in the UK either, right? Yeah.
We don't. There's some circumstantial evidence that it might have started in the UK back in September, but we don't know. And until we go looking elsewhere, we don't know.
So the idea of the mutations is really interesting to me because, I have some basic understanding that it's likely that viruses follow a trend where they mutate and become more infectious but potentially less deadly to be more effective and do their job, right? And so does any part of you think that may happen when we pull the timeline out farther, that might happen with this coronavirus? Is there similarities with this coronavirus to the coronaviruses we hear that cause colds? 10, 20 years from now, is this just going to be a cold? I don't want to speculate too much in the middle of such a crazy situation, but it is really interesting to me. And I was curious what you thought about that.
Yeah, it's a really good question. It is true that in history, with most big outbreaks, you've tended to see viruses mutate towards becoming less lethal. Though there are instances in history where viruses have mutated to become more lethal. We actually think the 1918 flu pandemic, during the pandemic that was going on, it became more deadly, not less over time, may have been the reason why there was so many more deaths in the second wave of that pandemic. So there's a bit of tempting fate here because you don't exactly know how the evolutionary pressures on the virus will play out. Over the long run, I think you're right. Over the next 5-10 years, over time, you would think the evolutionary pressure would make the virus become less deadly. The problem with that also is that we're also about to put a huge evolutionary pressure on the virus, and that's called vaccinations, right? So when we start vaccinating people, and we haven't done very many large-scale vaccinations in the middle of a massive outbreak. What's going to happen is you're going to put a very strong evolutionary pressure on the virus to try to escape from the vaccine. And whether those mutations will lead the virus to become more deadly or less deadly, no idea. But again, I think the best way to handle this, if we could just sort of really manage this, is stop the spread, slow it way, way down, immunize everybody, and then get life going again. But we're sort of letting it rip. We're letting, hundreds of thousands of people getting infected every day. So in that context, it's pretty tough.
Yeah, I mean, I think about that a lot because obviously the vaccine is such a great thing on the horizon and even now being distributed. But you compare that to the behavior of, most of us every single day. And so I just, it's hard to wrap my head around the idea that 80% of us will get vaccinated and, will really turn the corner on this very quickly. And we're hearing that, toward the end of 2021, we may be at a point where that could be likely, and that would be amazing. But I guess I don't know enough about how the vaccine will actually stop the spread significantly and how quickly does that happen. Let's say if by June we do have that 70-80% level of vaccination, does that mean that going forward it just kind of stops in its tracks, or is it a gradual decline? How does the vaccination stop the spread, I guess?
Yeah. So let's talk about this idea of something called population immunity. People talk about herd immunity, which is a term I don't really like because it literally comes from cattle. So let's talk about population immunity in humans. Here's the basic idea of population immunity. Let's imagine I am infected and I go out and see a bunch of people. If every one of the people I see is susceptible, then any of them can get infected. But imagine that I go hang out with two friends and both of them are immune because they're vaccinated or they've been previously infected. Then I can't spread it to them, right? And so my ability to spread the virus and for the virus to kind of grow in the community and spread is dependent on how much immunity there is out in the community. So people talk about a threshold, a herd immunity threshold of 60 or 70 or 80%, but I actually think of it as a gradation. It's not like a magic switch. And so we think that once you get to 35, 40% population immunity, whether it's through infections or immunizations, things start slowing down. So when I look out to 2021, just about to start 2021 and very soon, when I look at the year, I think by February to March, we should be at 30, 35% population immunity between infections and vaccines. And you're going to see the virus really starting to slow down. And then as that number climbs, you're going to see further slowing of the spread. And by the time we get to the summer, I'm hoping we're at 60, 70%. That'd be awesome. It will require people getting vaccinated, but I think most people want to get vaccinated. And at that point, you'll still see little outbreaks. You'll still see a little bit of infection here or there, but you won't see these huge outbreaks. And levels of virus in the community are going to get very, very low because so many people are immune to the virus. And that's when life really begins to get back towards some sort of normal.
Yeah, that makes sense. And so, is the vaccine going to provide protection for a year, 6 months? We don't know until we just see it. That may be determined with the mutations too. Is that kind of something that you have to just ongoing manage?
Yeah, so the short answer is we don't know, right? Like we just made this vaccine, it's relatively new. It looks really good on testing and all the clinical studies look great, but we don't know what the long term is going to be. But it's not like we have no idea. We actually do have some ideas. And my best guess, based on 2 doses, everybody's going to need to get 2 doses of these vaccines, is you're going to have immunity for a good period of time. What do I mean by that? Longer than a year, probably not a lifetime. So it's probably not one of those like you get it, once and you're done. That's probably not right. But can I imagine that it could last a year or 2? Absolutely. We'll have to see. And what it may mean is a year or 2 from now, people may need to go back and get a booster shot. Okay, like that seems not crazy. It may even be, I doubt this will happen, that we could have to get an annual COVID shot. But the way I look at it is I get an annual flu shot every year. If I have to get an annual flu shot and a COVID shot, like a little annoying, but not a big deal. I'll be happy to do it.
Could they even combine them together, or would that not work?
Probably not.
Yeah.
They're just different vaccines.
Yeah.
But, people are going to work on like trying to make them so they don't have to be a shot. Maybe they can do an oral version. I don't know. People are going to try to do a lot of things to try to, but it probably will be a shot. We may just be stuck with having to get it for a while.
So does the vaccine produce, I'm hearing a lot about this idea of T cell immunity versus antibody immunity. Could you explain the difference of that, and then maybe how the vaccine works with those different things?
Yeah. So immunity is super complicated. There are really many, many facets of it. And the best immunologists in the world will tell you it's way more complicated than it even appears. But I'm going to sort of simplify it because I'm not an immunologist. I'll give you my simple understanding of immunity, which is approximately right. Basically, there are two arms of the immune system. There are many, but let's focus on two. What's called humoral immunity and what's called cellular immunity. So humoral immunity sounds like humor, but it's basically the idea is these are antibodies made by B cells. These are lymphocytes, B cells, and they make antibodies. And so basically what happens is your body sees a foreign protein and says, wait a second, that's not normal. We don't expect that here. That's not one of us. And basically makes an antibody to that protein. And then it keeps certain amount of memory B cells around. The next time it encounters that protein, boom, produces a ton of antibodies and clears that. That's a pretty classic what's called humoral immunity response. Then there's a cellular immunity, and this is what people talk about as T cells. And these T lymphocytes are similar in ways, but also different. What they do is they go around looking at cells in your body for foreign and unusual proteins. If they see a cell with a protein that doesn't belong on the surface of that cell, it's that T cell says, whoa, that cell is infected with something bad. And it kills that cell. And it also learns what was that thing that it was infected with. Yeah. So you got two arms of your army. And basically, both of them are super helpful. And you ideally would have both for this. Now, you don't necessarily need both. You could get away with just one, not as good. What we have learned about these vaccines is it stimulates both your cellular immunity. So your T cells are can now recognize a cell infected with the coronavirus, and your B cells that your body can make antibodies to the coronavirus. And that combination is what makes these vaccines so powerful.
Mm-hmm. That's really interesting. And is there any indication that, the T cell immunity might last longer than the B cell, or we just don't know?
We don't know. And people talk a lot about how the antibody level. So one of the things you've seen a lot of news reports, people saying, antibody levels dropped, you can't detect them anymore. And I'm always like, chill out. A lot of times people's antibody levels drop. Doesn't mean they don't have antibodies anymore. It just means it's at a low level. And the next time the body sees the virus, it'll ramp it up again. So I have actually pretty good confidence that both arms are going to last for a long time. And I don't know if one will last longer than the other. But I think we have pretty good reasons to believe that if you've been infected, you should probably be immune for at least a year. I shouldn't say at least a year, probably at least 9 months, maybe up to a year. But if you've been vaccinated, I suspect you're going to be immune with both B and T cell immunity for even longer than that.
So I want to go back to kind of what the virus is doing to us when it's infecting us a little bit, and talk a little bit about that, and then go into more public health type of discussion. So another thing that I've been finding really interesting, trying to read about, but getting kind of a mixed understanding, is the idea that this is maybe a really unique virus, and it seems to affect the circulatory system in some sort of way. And, you're hearing people talk about blood clotting issues and strokes and myocarditis, heart infections. And so is that, is it more common with this virus, or is that something that's getting blown out of proportion from a reporting standpoint, or is that actually pretty significant and maybe unprecedented from a virus in terms of what it does to the circulatory system?
Yeah. So first and foremost, I don't think it's being blown out of perspective here. This virus is very strange, Cam. Here's why. there's a chunk of people who get infected who barely even notice that they had it. They might get a little headache, a little mild fever, and a little runny nose, sore throat, and then they're better. And then there are a chunk of people who get super duper sick, and obviously either a chunk of people who die, and everything in between. There are very, very few infections I can think of where the range of response is that dramatic. And it makes you think there's something more than just the viral infection that's going on. So let's talk a little bit about what we do know about this virus. For some chunk of people, they get infected, their body responds really effectively, clears the virus, they do great. There are other chunk of people where the body's response is not quite as effective. We think maybe that's partly why elderly people get much worse. Manifestations are more likely to get sick. And what'll happen is a virus will replicate. Now, it does a lot in the lungs, where the primary effects are. And then here's where the science gets a little bit more murky. There is evidence that the virus can actually infect cells that line the circulatory system. But there's also evidence that what is happening is that the virus and the infection is triggering an immune response that's actually causing damage in the circulatory system. And it's the immune response that's leading to clots and leading to all of the awful other manifestations, the myocarditis, the strokes, the heart attacks. And what we don't know is how much of that is direct infection, how much of that is the immune response. My guess is probably a bit of both. When you can't quite sort it out, it's probably both. And in different people, maybe different amounts. And what we think is that early in the disease, it's all virus. It's the virus causing almost all the problems. And late in the disease, for people who are really sick, it's all immune response. And it's the immune response that's really has gone haywire. And so what you want to do is early in the disease, you want to treat the virus and try to slow down viral replication. And late in the disease, you want to try to manage the immunologic response. And that's why treating the virus late in the disease does nothing useful. Giving antivirals does nothing useful late in the disease because it's too late. It's the immune system has now taken over.
And you think that if you're potentially treating the virus early on, then you can potentially avoid some of those problems that might occur due to the immune system's kind of overreacting response.
Exactly.
Right.
That's the hope. That's the plan. And so that's why we've tried some antiviral things early, like remdesivir is a drug that has gotten approval in the United States. Some controversy of whether it works or not, but most people believe that it works a little and it works when you give it super early because it's an antiviral that slows down replication. We have these new drugs called monoclonal antibodies developed by a couple of companies. They're antibodies. So basically, they're like your own immune antibodies, but basically these are engineered in the lab. And we think they work really well if you give it early in the disease, because again, before the virus really has a chance to take over. Versus something like steroids, which are these very powerful steroids, dexamethasone, has a huge benefit. But if you give it early in the disease, you actually kill people. Because early in the disease, you want a good immune response to fight the virus. Late in the disease, in seriously ill people, that's when you give them steroids. And that's what helps in terms of preventing a lot of deaths. So it's a very tricky virus to manage.
There is also some indication that potentially there is maybe some infection going on with the actual circulatory system, and is that, again, with ACE2 receptors? Is that the same idea?
I think it's primarily through ACE2 receptors, but there's a lot of work being done on this, and we don't know all the details. You definitely can find ACE2 receptors in lining the endothelium of the endothelium is a cellular layer of the blood vessels, the internal layer, and so we definitely have evidence that the virus can infect those cells. Is that what's causing the circulatory system problems, or is it actually a clotting from an inflammation? We don't know. And that's still being sorted out. And people are trying all sorts of different therapies. People are looking at this in the lab. Lot has been learned, but a lot we still don't know about this virus.
And from a public health standpoint, are you thinking about now going forward when we get into this, next phase of kind of manage, maybe assessing the damage of what's been happening? Is that something that you're thinking about in terms of potentially long-term effects from people who had severe cases, along the lines of these type of problems that we're talking about?
Absolutely. So I think a lot of people like to focus on the mortality rate is X and only a certain proportion of people die. That's true. Mortality rate of this virus, again, much worse than the flu, but it's not horrible. Probably about 1% or a little less. About 0.7%, maybe 7 out of 1,000 people who get infected die. But a lot of people who get infected end up getting quite sick, and then they may recover, but we don't know what the long-term functional effects are. And we don't know what the effects are on the heart. We don't know what the effects are on the lungs. We don't know what the effects are on the rest of the body. And I'm very worried that we're going to have millions of Americans who are going to have serious long-term disability coming out of this. And that's going to be awful for them, their ability to work, their ability to lead kind of long, healthy, productive lives. All stuff we're going to be sorting out for many, many years to come.
So, we're obviously seeing such a stress on the healthcare system, and there's another kind of, interesting thing, or potentially scary thing going on within the healthcare system. People aren't really interacting within the system like they usually would in terms of getting checkups and screenings, everything like that.
Yeah.
How do you think that we address that while this is ongoing, through the next few months until we get vaccinated? And is that something that you're also keeping an eye on?
Yeah, so let's talk about what's happening to the health system. And here are maybe 2 or 3 points I think worth making. First of all, certainly right now, here we are, end of December, huge stress on the health system. In California, LA, you're really kind of ground zero for that. But there are lots of places across the country where hospitals are full, ICUs are full, real problem. So there are those. But what happens when that happens, Cam, is that hospitals essentially stop doing a lot of other stuff. They cancel elective surgeries. They really will be only doing the absolute bare minimum of other stuff because they got to keep their rooms and staff ready for COVID, right? So there are all these spillover effects on everybody else. So if you need a hip replacement, you need a knee replacement. A lot of people, cancer surgery, which we don't think of as elective, those are getting postponed or even canceled for months because there's just no room. So that's huge. But the other part that's, of course, happening is all of the other health needs that people have. People are not going to the hospital. They're even nervous to go to the doctor's office. And what I've been saying to folks is like, look, if you feel sick, you should go. Because hospitals have gotten much better this time around at figuring out how to still take care of you and keep you safe in the hospital. So I don't want people to hear this and say, oh my God, if I'm having problems, I should not go to the hospital. Like, let them sort it out. But let's be very clear, when the surge gets as bad as it is right now, it's affecting everybody, whether you have COVID or not. And that is a real problem. And we're going to see the effects of that for a long time as well.
Yeah, I mean, I see it right now in California. I mean, you're right. It is really feeling like ground zero. And, quite frankly, what's interesting is that we put in place these guidelines, and now we're back on lockdown, quote unquote, which I don't like that term because it gives a negative connotation.
I hate it too.
But it doesn't really seem to be making any difference. And I just think that people's appetite for it is just gone. We can't go to restaurants, and I haven't gone to a restaurant since this started. But now, people in California, in LA can't go to restaurants again. But that's pretty much it. Like, all of the other measures that they instated are not really being followed, and there's no consequence to it not being followed either. And, I see people, gathering in groups at, apartments all around my building all the time.
Yeah.
And so, yeah, I mean, it's I really do worry a little bit that fatigue element is also, taking part. And so that stress to the healthcare system is probably not going away anytime soon.
Yeah. There are a couple of things that are happening there that I think are worth talking about. I mean, one is we've had, I think we should just be honest, we've had 6 months of a relentless misinformation campaign, really spewed by a bunch of folks saying, hey, it's no big deal. It's just the flu. Don't worry about it. It's only the elderly. It's only people over 80. And it's nonsense. It's not true. And it's not true in 2 ways. I mean, and this gets to the second point. One is there are young people. I mean, obviously young people do better with this disease than old people. No doubt about it. Much, much better. But there are young people who still get sick. And there are definitely young people who've died. but more importantly, not more importantly, but as important, like young people who've gotten pretty sick, who've had like heart damage and lung damage. And like, if you're 25 and, you know, you've had serious lung damage out of this disease, like, I'm not sure that's a great outcome. You've got a long life to live. So there's that. But actually, just as importantly, what's happening is it's true that that 25-year-old may not get sick. Actually, 25-year-olds often will get infected and have very mild or no symptoms at all. And then they go visit their 60-year-old or 50-year-old father or 80-year-old grandmother and give it to that person. Or see the grocery store clerk who's 55 and give it to that person. And you're doing it without knowledge because you feel fine. And that's actually the big problem, is that the outbreaks often begin in young folks who feel fine, but then they spread it because young people and old people don't live in different worlds. Like, they actually interact. They actually physically end up in the same space, on a subway, in a Uber, in a whatever, right? So this is the problem, is that we all live in one country, one society. And when and the misinformation around telling young people not to worry about it has really made it hard for people to kind of pull it together. I will say one last thing. I don't mean to ramble too much here, but one last thing is these lockdowns that California has imposed, they are pretty tough. It's hard for people to follow. We don't need to do this for a long time. Like, we just need to do it enough to break this cycle that we're in and start getting vaccines out. And that's like 4 to 6 weeks away before things will really start getting better. So what I've been saying to folks is, I know you're tired. I know it's been a long time. Like, a little bit longer. We're like so close to the end zone here. This is not the time to let up.
Yeah, I completely agree. And I mean, it's, you know, it's the sad kind of irony of it is that if we all came together in a common way for just a small amount of time, we could really make an impact. But there's just not consistent messaging. You know, it's tough because everything is state by state. And in California, you know, a lot of people have been, you know, really kind of just debating, you know, the messaging and the state government's kind of handling of the situation. And I've got friends who work in the restaurant world, and, you know, they're really affected. And, you know, people own businesses and need to have their livelihood, and it's really tough. And, you know, it's really difficult when there's not clear messaging, there's not clear support in any type of way for these small businesses. And, you know, we can't figure out a way to kind of come together and, you know, just try and lock it down for 4 weeks and slow the spread and then, you know, get to the next phase. You know, has that been something that's been frustrating at all for you, the inconsistency of the messaging on a nationwide basis? And
it drives me nuts. Like, literally, this is what I spend probably a majority of my time on, is I'm spending a lot of time talking to governors, mayors, health secretaries across the states. And there are 2 or 3 things. I mean, first is we've had no national strategy. It's really hard to fight a pandemic 50 states at a time. Every state's got to figure this out on their own. It's just really, really hard. And every state is different. You do want to customize things a little bit, but there are some common themes. Like, you know, I think about restaurants. So I love restaurants. Like, I love food. I love going out, what I do socially, professionally. I haven't been to a restaurant, sat inside a restaurant since I think March 2nd was my last one that I did. So, you know, it's been a long time. And I think about all the restaurants that I love, and I think about their workers and the businesses, and like, it's awful. So what do? Like, we could just open them up and then let everybody get infected, hospitals get overwhelmed, and then people will stop going to the restaurant anyway. Well, that doesn't sound smart. What we should be doing is we should be providing support for restaurants. Again, we're not talking about forever. We're saying, and now we're probably like a few months. Like, give the small business owners some money to get through this period, pay the workers, and like, let's get through this. And then as soon as it's safer, like, I'm going back, right? I'm going back to the restaurants or the bars, and it'll be great. But we got to get through this. And the problem is Congress has not stepped up with money. And now there's a COVID relief bill that we'll see what happens. And so then governors are basically, when I talk to governors about restaurants, they're like, look, what I'm stuck with is I leave the restaurants open and my hospitals get full and lots of people die. I close my restaurants and people go out of business and workers lose their jobs, and they lose their homes, and they become homeless, and that sucks. And like, these are my two choices. Which one? And I'm like, I hate both of them. We should be able to come up with a third choice, which is like, keep the restaurants reasonably closed and protect the workers and the small businesses for the short period of time that we have in front of us, get through it, and then open things back up again.
Yeah, and do you think that we could have done a better job on this? I mean, I debate this a lot because we are America. We're a very unique country. We're not New Zealand. We're not, any of these countries who've really done a great job, and it's commendable and amazing. And I think we all wish we were in New Zealand right now, having the time of our lives.
Yep.
But, do you think that we were just so unprepared, or it was the decisions that were made at the time they were made that were the wrong ones, and it got us here, and we really could have done that differently, and it would have made an impact.
We definitely, we could have done this bit differently. And look, we're not New Zealand. New Zealand's like 5-6 million people. It's an island nation. We're like, we're 60 times bigger and complex and large and all that stuff. But we don't have to be New Zealand. We could have been Germany. Germany's a big country, complex, got lots of state rights issues. And Germany's had like a quarter of the deaths that we've had. And the difference between Germany and us is they've had pretty consistent messaging. They've had federal leadership. We actually started out okay in some ways, right? Like, we had support for businesses in April, May, June. There are things that we screwed up on. We never fixed our testing infrastructure. So we just never really got testing going in a way that would have made a huge difference. We didn't really get the messaging right. People still think mask wearing is somehow a political statement, which is insane. Like, I mean, I don't know, drinking, driving, a political statement? No. Like, I don't care if you're a Democrat or Republican. Don't drink and drive. Right. Same thing. Like, wear a freaking mask when you're out and about. Like, it's the right thing to do. And we've gotten into these things. I have to say, and I'm not deeply partisan, but this year, like this coming in during the presidential election year, I think made things much, much worse, because the reaction was to turn a lot of this stuff into partisan politics. And it was totally unnecessary. Like, again, I literally, like, I think of mask wearing like drinking and driving. Like, you don't do it because you don't do drinking and driving, and you don't not wear a mask because it's like you can hurt somebody, you can infect somebody, you can kill somebody. And we just I don't think of those things as like partisan, like, if you're a liberal or a conservative. Got to think about this stuff in the same way.
Yeah, it's really just weird to see the idea of science be so polarizing right now and politicized and everything like that. So going forward, what do you think are the steps that we take from a public health standpoint, messaging standpoint, that will make a difference here? And I think the circumstances are different. We now have a vaccine, multiple vaccines. I'm sure there'll be a lot of, efforts to send out messaging on that. But what do you think we should be doing in terms of a public messaging and even policy standpoint?
Yeah, 3 or 4 things. So my goal is, I want us to get back to some semblance of a new normal, and I want to get back to that with as few Americans dying as possible and as quickly as possible, right? So what's realistic? First, there's a short-term problem, which is the next, I keep saying 4 to 6 weeks. Could be 8 weeks, but it's not going to be longer than that. So let's say we're at the end of December through mid-February. Things are going to be pretty tough. And what I've been asking people is, like, hunker down. Like, don't socialize. Don't gather outside of your bubble. Just hold off for 6 weeks. That's what we're talking about. Because by 6 weeks, by mid-February, enough people have gotten vaccinated and other things will have started kicking into play that I think really will begin to make a difference. So that's one. It's like, really avoid the gatherings for the next 6 weeks. And remember, the virus spreads when you gather with people and you're not wearing a mask, and especially if you're indoors. So don't do it. Second is, we got to start getting these vaccines out as quickly as possible. Now, production is going as fast as it can. I think the ramp up in the next month or two is going to be slow. It depends on what you call slow. It's going to take a little while to get a lot of vaccines out, but we got to keep pushing on that. The third thing, which I've kind of alluded to, but is huge and makes such a big difference, is testing. So let me just tell you, I just started this fall at Brown University. And at Brown, we were testing everybody. We had students back on campus, classes in person. We were testing everybody twice a week, faculty and staff and students. And there were really large outbreaks in Rhode Island and Providence, but almost nothing at Brown. Basically because every time there was anybody got infected, we identified them right away because you're testing everybody twice a week. We just need to be able to do large scale testing. If we could do large scale testing, especially at home, like imagine you could test yourself at home twice a week. You wake up, you get a test, 15 minutes. If you're positive, okay, you can't go out that day. Like you got to isolate. That kind of testing is going to make a huge difference. It's coming. And the Biden team has been very, very clear they're going to make that pretty widely available. And then what people need to do is wear a mask. Really, it does make a difference. People do that stuff. You'll see life begin to change in February. You'll start feeling better in March, April. May and June are going to be good months where you'll be like, oh yeah, not 100% normal. Maybe not a packed concert. But a lot of the stuff that we really value will start coming back kind of late winter, early spring. And we're so close. But if we don't do these things, it's going to be a slog. It's going to take longer, and more people are going to die, and it's going to wreck the economy too. So we don't, there's no upside to not doing these things.
Yeah, and I hope that once we start seeing some of the positive effects from people getting vaccinated, and maybe the curve starting to go down, maybe that'll incentivize people to start doing their part a little bit. That one can only hope. So I've got a couple more questions before we wrap this up. I'm just curious, how have you been adjusting to this? I imagine this has probably been a pretty crazy year for you personally. And I can't imagine how busy you've been, and to be busy during a pandemic, and then feeling the stress as all of us are, and probably way more so being so close to it. How do you manage that?
I appreciate the question. It's been a crazy year. I mean, I guess I start by always reminding myself that it's been a crazy year for me, but it's been so much harder year for so many other people, right? I've had a job the whole time. I mean, I switched jobs, but I've gotten paid the whole time. I haven't worried about losing my house. I haven't worried about putting food on the table. So all these incredibly stressful, and obviously, thankfully, I've not lost a family member. That set of stuff is the awful stuff that people have had to go through. And at no point do I ever feel sorry for myself, given what people have experienced. Now, that said, every once in a while, I feel a little whiny about how hard this year's been. I had all sorts of other plans of what I was going to be spending my spring and summer doing. And I, basically have been spending almost all of my time thinking about COVID and working on COVID. And because it's the issue of the day. Our country's in big trouble. We've had so many people die. It's done so much damage to our economy. And I felt like if I can contribute in a positive way, and if I can communicate, and if I can help policy people get answers right, then it's my job to do that. And so I've been plugging away. It's been probably less sleep and more tiring than anything else I've done in a long time. But I feel like it's, at least most days, I feel like I'm making a difference, and so I keep going.
Well, I know you absolutely are, and one of the things that I admire about seeing all of your different interviews and everywhere that you've been speaking, it's just inspiring to hear the optimism, just the idea that we can get through this. Let's think about this pragmatically, and come together, and we can get through this. And I think that. I think I heard you say in another interview that, this is America. This is what we do. We did it in World War II, and, all these different times in our history, we've come together and figured it out. And it's tough, and there are really hard times, but we will come together and figure it out. And I hope that that's the direction that we're going in, and it seems that we are. And I'm excited to maybe excited isn't the right word, but I'm looking forward to see these next few months play out with the vaccination distribution and everything like that. The last question I have for you is just the idea that when we come together to fight this, common enemy, this virus, and in times in the past when we've come together and fought wars and overcome difficult times, there's been so much innovation that's happened as a result of that. And so, being a public health guy, are you feeling good about the fact that there's going to be some significant medical innovation that happens as a result of this? And is that a silver lining here that you might think about sometimes?
Yeah. So let me maybe make 2 points on this to finish. Point number one is what has happened with the vaccine is unbelievable. How amazingly impressive it is that the scientific community came together. We just built whole new vaccine platforms that we didn't have. We built these mRNA vaccines that are turning out to be incredibly safe, very, very effective. And now a lot of years of work went into that, but people came together around the globe. It wasn't just Americans. It was scientists in Germany and UK and Turkey and South Korea and elsewhere. So it's a true global effort. And it's a reminder that when humanity comes together, we can do unbelievable things. But to your question around innovation, it also is a reminder. Like, we're never going to make vaccines in the same way again. Like, the next time there's an outbreak, we're going to totally do this differently because we have now proven that we can build vaccines much more quickly. So I think that's really impressive. And it's going to absolutely, there's a whole bunch of medical innovation, our ability to come up with new drug therapies, monoclonal antibodies, all this stuff. Very impressive. I think where I am looking to the next 6 months, Cam, is now we have these vaccines. Awesome. But vaccines don't save lives. Vaccinations do, right? Like we always say that. What does that mean? We got to get these vaccines into people's arms. How's that going to happen? There's a whole ton of like logistical challenges, but a lot of social challenges. Like, we got to make sure that like we get it to people who are poor, who are more in marginalized communities, and Black and Latino people who have been disproportionately hurt. There's a lot of social innovation that needs to go into building trust with communities, helping people understand. And I'm hoping that the next 6 months, we also learn a lot about how do we come together as a community to solve this. So the scientific community did a brilliant job, but now the rest of us have to come together, communicate openly and effectively, figure out how to get these things out to people. I think if we do all of that, as I said, the winter is going to be tough, but the spring is going to be nice and the summer is going to be awesome. And like, that's what we have to look forward to. And I don't know, like, I'm just, I guess, kind of hopelessly optimistic about America and our ability to do these things. I am very optimistic that we're going to figure out how to do this, get vaccines to people, build the trust we need, and get our economies back and get our lives back.
Well, I think we will get there because of people like you who've been stepping up and relaying these important messages and just being such an important voice on everything that's been going on right now. So I'm honored, honestly, to have the time to have spoken with you today, and I just really appreciate it, and I really enjoyed the conversation. I hope we can do it again a little bit later on.
Well, I as I said, I loved the fact that you reached out. I was delighted to do this, and this was a lot of fun, and I would be happy to take you up on the offer of coming back. So let's do that some point in the spring. Let's hope that I was right.
Yes.
I think I will be about the optimism. And until then, stay safe and stay well. And thanks again for having me on.
You as well, Dr. Jha. Thanks so much. Have a great rest of your Sunday.